Okay, questions, follow-ups from last week, open forum. I know there were a couple of follow-up items from last week. And I see hands up. Ashley?
Yeah, hi. So I just had a question regarding last classes, like last lecture. I know you had mentioned for NSAIDs that when they do like a coating or like a delayed release or anything like that, like it doesn't really do anything as far as like protective effects, like for gastric bleeding. So what would they be used for, like in that case? Is it just like a marketing scheme to make people feel like they're protected?
That's a good question. I'm speaking sort of endogenously from a biochemical perspective. There's no protective effect of buffering or even low dose. I showed you the data, 81 milligrams of so-called baby aspirin used for cardio protection, secondary protection, knocks out the gut protective PGEs as much as the 325 milligram does. So it doesn't make any difference. Maybe there's an effect that's direct contact related, that maybe there's a buffering effect where you avoid the I have no idea, the acetyl salicylic acid contact directly. I mean, you guys can look it up and tell me, but I think that's secondary to the GI protective effects of the mucosal lining related to the prostaglandin E series. That's the primary protective mechanism, and that's not related to any of those issues. Weird.
Okay, thank you.
It's a common myth, which I like to bust. Let's see, Michaela.
Hi.
Hello.
I just have a question about last week's lecture. So I just wanted to know, like, what kind of like health conditions would a patient have to be in for like a healthcare provider to not recommend a COX-2 inhibitor drug like aspirin for, like, pain?
Well, it's an interesting question. I think it's a complex one, actually. It's not that anyone who needs a chronic NSAID theoretically would benefit from a COX-2 specific inhibitor.
Mhm.
The problem is they're expensive and they're branded. And insurance companies don't like to cover them because they would prefer you take a non-specific COX-2 inhibitor and take the risk. Because the branded price of some of these are much higher than over-the-counter or even prescription strength meloxicam, which is generic. I think conceptually, everyone who's on if you want an occasional NSAID for aches and pains, backache, headache, no. But for somebody with an arthritic condition, it's really no justification for not being on a COX-2 specific inhibitor other than cost.
Okay, thank you.
You're welcome. Anna?
Hi. I had a question in regards for drugs that are made for rare diseases. I was just wondering if the pharmaceutical companies, like, do they have a harder time marketing these drugs because it's a smaller demographic that they're trying to treat, or does that make it easier for them to market those drugs?
No, it's a good question. It's easier and harder at the same time. It's a dual-edged sword. On the one hand, you could argue most of this easier to treat diseases have been addressed on some level. Hypertension, dyslipidemia, whatever. Anxiety, depression. As we move into rare and treatment-resistant disease, the markets get smaller, but also the potential reward or the prices go up. I mean, I'm working on a product now for one time, one and done potentially, although we don't have the data yet forever, for the treatment of hemophilia B. That's $3.5 million for one injection. So, not that they're all one and done, they're not all curative, or alleviate you from ever needing another treatment. But the more rare the disease tends to be, the higher the cost because there's a smaller market and they're more complicated pathways to unravel. The basic science is more complex as we get into immuno-oncology, different pathways, PD-1 inhibitors, VEGF inhibitors, bispecific antibodies. The basic science is more nuanced and complicated. patient population is tougher to treat, they get a premium price for those. So I think the answer is both. Good question. Olasami?
Yes, hi, good evening, Professor. So my question is, I think it's kind of similar to Michaela's question, but I just wanted to know, like, are there any drug interactions that patients should be aware of when taking NSAIDs, especially specifically patients who are on dialysis or kidney transplants patients?
Yeah, I think yes is the short answer. I think there was a slide on some of the directions. For example, certainly alcohol, not that it's a drug per se, but people do drink, and so it increases the rate substantially. Other NSAIDs that they're not aware of, people think because they're getting a prescription NSAID doesn't interact and is additive to over-the-counter ibuprofen, but also anticoagulants, the 10A inhibitors, rivaroxaban, apixaban, warfarin, Coumadin, anything like that would be a potential contraindication, or if not a contraindication formally, risk of increased GI bleeding. There may be others that I'm not thinking of.
Okay, thank you.
Yeah. I know we had some questions last week that I asked some students to follow up on. Anybody here with that? Okay. Mustafa asked, can NSAIDs ever replace opioids? Well, it's a fair question. As you move through the NSAIDs, you get into some of the very weak opioids, and there are some combinations. I forget what they're even called today, but they're weaker opioids in the oral. Is it Darvon I'm thinking of? Maybe Darvon. Somebody could look that up. But that's still an opioid, still a weaker opioid. But it depends upon the degree of the pain, Mustafa. It really does. I mean, it depends upon the severity of the pain. I was working for some time on a series of compounds that were non-opioid agents that promised the same pain relief efficacy as opioids. But they so far have failed to come to market. Furanumab was one from Janssen. It was discontinued before it hit the market. These were inhibitors of a different pathway. Let me look it up. Furanumab from Janssen. Yeah, nerve growth factor inhibitors. Monoclonal antibodies against nerve growth factor. That might have been an intermediary, non-NSAID, non-opioid. But then there's others, but they haven't made it to market yet. So I think to some extent, it's also what I said about appropriate dosing of NSAIDs. If you take a once-a-day COX-2 specific inhibitor, you can keep the blood level high enough to be anti-inflammatory and analgesic and antipyretic. Very few people who take an over-the-counter dose of an NSAID get up at 3 a.m. to take their 2 ibuprofens or naproxens. So you lose that anti-inflammatory effect. And when you lose the anti-inflammatory effect, you lose often much of the analgesic effect, particularly if your injury or insult is related to inflammation, which many things are. So I would say, Mustafa, that NSAIDs could replace opioids more often if dosing were maintained at adequate blood levels to maintain their anti-inflammatory efficacy, not just analgesic and antipyretic. Does that make sense? Okay. Well, you tell me, Rory, since you read the chapter. Yes, they do. Opioids tend to bind to the mu or other opioid receptors, and NSAIDs work. Can somebody tell me the mechanism of action of NSAIDs? COX-2 versus COX-1, but that basically they all work through inhibiting the conversion of essential fatty acids, arachidonic acid primarily, to the prostaglandin precursors. That was part of our discussion of the mechanism of action of NSAIDs. Yeah. So there was one item to mention to you all that came up during the week, or even yesterday or today, that some students who needed to review the recordings on the cloud, we're unable to access them because it's requiring a password. That was an error artifact of the Zoom system that Rutgers is using. Apparently, I got a note that it's being addressed, but if I did something that was quite complicated for me, I could obviate that, which I did, so you're welcome. I got online and hit a lot of buttons and file directions, and I think I got you all access. But they're working on it. It is an issue. I think I've avoided that. If anybody has anybody accessed any of the recordings this week?
Yes, I have, and they worked for me.
Or okay, when was that, by the way?
Today.
Okay, so whatever I did worked, and I may have to continue to do that if you need access to recordings. I hope they fix it, because I don't want to have to repeat the complicated series of buttons I had to push. Anybody have any follow-ups from research they were doing that who asked questions I didn't have the answer to last week? No? Okay, when we have these discussions, if we do ask you to do that, would you please do it? Because I really do want to know the answer, because if I don't know it, and you don't know it, then we don't know it. And it's better if we get some kind of a response. Okay, anything else before we jump into tonight's lecture and discussion? Am I missing? Okay. What? New. I don't know what that means, new. Okay. All right, so let's talk about tonight's topic, MS. And we're going to focus on the T and B lymphocytes discussion, differential immunopharmacology, and the marketing of Gilenya and Aubagio, the first two oral MS agents. And I've worked for both Sanofi Aventis on the launch of Aubagio, teriflunomide, and Gilenya with Novartis at different times, obviously. So I'm going to kind of tell you my cut at what I did to drive the market for both, because prior to the oral agents, there were really very few effective drugs for the treatment of this devastating disease, this parent autoimmune disease, other than the interferons, which were not that effective after a period of time. They stopped working. So as always, we're going to get into the basic disease state. We're going to talk about the pharmacology, the differentials, and then we'll get into what Novartis and Sanofi did to differentiate themselves, their first oral agents, because the interferons are injectable, in this increasingly crowded and complex marketplace. And I'm going to go, again, as I always do, fairly quickly through this. And when I get to the points that I really want you to know for the exam, and really less for the exam, but for yourselves in the future, I'll tell you. This is important. This will be on the exam. This is the take-home message, or something like that. I always will. So, from a disease state, MS, it's an autoimmune disease, central nervous system, progressive neuronal loss, impairment of nerve signals, muscular contraction, coordination, strength, sensation, early vision problems are usually telltale. Often relapsing and remitting initially. And again, as always, this is not today's medicine or even today's numbers. So I'll just tell you, at the time, this was the epidemiology, under 300,000 diagnosed, a little bit more common in women, 20 to 40 peak years of career and family development, devastating. Most of it is relapsing, remitting initially, but becomes progressive disease. And we know a little bit more about the underlying etiology and pathophysiology than we knew back at this time. We really don't know for sure whether there's some triggers. It certainly looks like an Epstein-Barr virus is etiologic in this condition based upon a very large veterans cohort study that identified that virus in a significant percentage of soldiers who developed MS. So that does seem to be an etiology that is some interest. But as damage to the myelin sheaths cumulative over time becomes irreversible damage to the axons. Therefore, you lose all the important neuromuscular issues that are involved. It's really the most common cause of non-traumatic disability in young adults. And we'll talk about the progression of the disease in a few minutes. The name multiple sclerosis actually means many scars. Now, those are the lesions that accumulate in the brain and spinal cord. The autoimmune nature of the attack, for whatever set of reasons, maybe viral etiology, that the the T cells mistakenly damage the myelin sheath, protective layer that surrounds and insulates the nerves, almost like a wire's insulation, ultimately resulting in injury and death to those nerves and impairment of the nerve control signals. It's a neurodegenerative disease that has typically worsened over time. Usually MRI detected lesions are cumulative even before symptoms are fully present. So we've talked about this. Is there a genetic component? It's not completely clear. Is there a viral? Certainly Epstein-Barr seems to be correlated more than anything else we've seen, at least from the data that I've seen. But certainly what we do know, whatever causes it, T cells become sensitized to the myelin and attack it. And the T cells injure the myelin, secrete inflammatory mediators that damage the nerve fibers, recruiting more damaging immune cells and resulting in the demyelination. We think about very early MS as the CIS, clinically isolated syndrome, as a precursor to the disease. This is pretty common that within 5 years of having these CIS isolated symptoms, often involving blurred vision, some weakness, mono or multifocal episodes, up to 80% of CIS sufferers go on to develop MS within 5 years. Usually the relapsing remitting form initially. And so we think of MS classified into various subtypes. As I mentioned, 85% of MS initial diagnoses are relapsing remitting. Patient has exacerbations or remissions. Can become secondary progressive disease, which is more aggressive. There can be primary progressive MS, which is typically only about 15% of patients at the time of diagnosis. And we had no good treatments for that until very recently with some of the monoclonals, and then becomes progressive as well. Another way of looking at that, the primary and secondary progressive disease. And you see here the nature of clinically isolated syndrome becoming relapsing remitting disease. Increasing disability has become secondary progressive with fewer remissions until the disease just is progressive, as opposed to primary progressive out of the gate, which never has periods of remission, just periods of exacerbation. The majority of patients who develop initial relapsing remitting without effective treatment will go on to develop primary or secondary progressive disease at some point, hopefully later. And as I mentioned, about 15% have primary progressive disease right out of the gate. Now, if you look down at the breakdown, this gives you some of the numbers depending upon who reports it as to primary progressive rapid relapsing remitting disease. I mentioned about 300,000 diagnosed in the US each year. You can see how the relationship between diagnosis and drug treat is pretty close, because it's such a symptomatic disease when it finally manifests itself. people want treatment. This shows the breakdown by gender, showing that the relapsing remitting is 2/3 female, 1/3. And then as the disease progresses, or if it is a primary progressive MS, tends to be more even, possibly even more men developing progressive forms of the disease. The onset typically occurs before age 50. You can see the breakdown here. So 28, 30, 40, 50, 60% happens, 70, 80% happens certainly between the ages 20 and 59, but just 20 to 50, 20 to 49 is almost 60%. And that's pretty devastating with, you know, a mean age of the population of 40, but look at females to male age of onset. This is when people are beginning their careers, potentially families, balancing and juggling an awful lot of responsibilities and pressures. And they end up with a disease that, until really very recently, has had very poor therapeutics. And patients will go on to become quite disabled, and as you'll see in a minute, really impairing their quality of life on every level, their ability to maintain employment and relationships. Just an awful quality of life and set of conditions. What's happening neurophysiologically with the demyelination is captured in this cartoon. You can see the nerve fibers, the damaged neuronal sheath with the T cell attacks, and the so-called saltatory conduction is where electrical impulses would jump from the open exposed fiber or wire, if you will, from point to point myelin and move much faster. And then when that's broken, it has to move in this kind of linear fashion as opposed to this exponential fashion. And that can be measured through electromyography and other forms that show the much slower rate of electrical conductance in patients with MS. As I mentioned, relapses are a clinical manifestation. They occur more often as the disease progresses. And you can see the progression of disability on the expanded disability status scale. In these days when I was doing this work, this was the primary method of assessing patients' progression of disease, often used in clinical trials. And you can see 0 be normal, no disability, minimal disability, people going from walking to a cane, from a cane to a wheelchair, wheelchair to bed, bed to death. And patients, you know, we talked about this in diabetes students. You don't often see on a death certificate MS or diabetes. Yet, can you all go on mute who are not talking? So I'm hearing a lot of background noise. Thanks. So it's hard to say whether we have accurate data for the mortality rate related really directly to MS. If a patient dies of let's say infection, systemic bacterial infection because they were bedridden. Did they die of infection? Well, I guess proximately, but wasn't MS the cause of death? So I think we see the same thing in many other conditions, particularly things like diabetes. You had a heart attack or a stroke and you died. You died of the heart attack. No, you died of out of control diabetes that led to the heart attack. I think the same thing is true here. Very much underreported cause of death in poorly treated patients. This shows the natural history and the implications of MS from the preclinical CIS. You can see the scores of the expanded disability scale start to go up. The predicted costs go up. The MRI lesion burden goes up as it goes to relapsing remitting to secondary progressive disease, and therefore the dollars go up. And this is a picture of a brain with the MRI enhanced, contrast enhanced lesion numbers. You can see over many years of clinical studies that the EDSS score is linearly related to the accumulation of lesions in the brain and the spinal cord. And here you see an EDSS score of equal to or greater than 6, with 40 to 50 lesions cumulative. Half of that, smaller number, not completely linear, but somewhat. And there are many clinical symptoms associated with MS. So in the relapsing remitting patient, very often you see fatigue, listlessness, tired, numbing and tingling, balance and coordination problems. These are the early manifestations of relapsing remitting MS. But spasticity and tremor in over half, visual problems, bladder dysfunction, pain syndromes. As patients progress with this disease to secondary, all of these go way up, and you can understand how patients with all these symptoms become additive: fatigue, numbing, depression, spasticity, tremor, bladder dysfunction. We talked about patients not wanting to be wet. Almost all have coordination problems, falling, bowel dysfunctions, to the point where patients who have advanced secondary disease, primary or secondary disease, may be completely have no bowel control or bladder control. Very hard to function in any meaningful way, in any average way under those conditions. So people don't think about how cumulative these symptoms are and how devastating it can be to a person in their 20s, 30s, 40s, or early 50s. It's a nightmare. And so patients with progressive disease report more severe symptoms. You can see the severity based upon the progression of the disease increases with the severity of the disease, not surprising. The burden on patients and on caregivers, comparing more mobility, half or more suffer impaired mobility, trouble walking, miss the common social events, work events, self-esteem, depression, lifestyle modifications, the relationships suffer, mood swings, sexual dysfunction. The caregivers suffer, family members suffer as well. Self-care can become impossible, and the financial and emotional and physical burden for caregivers is an enormous issue. I take issue with this statement. I don't think that's accurate. Probably needs to be updated. I don't think it's 95% of the normal life. I think it's much less than that. From an employment perspective, you can see that over time, up to 80% of adults with MS are unable to work consistently. And again, I caution that this was the situation, how long ago was this? 10, 15 years ago. It has improved. The medications, the treatments are much more aggressive and effective. But, we're still on this curve. I think we've been able to slow down this disease, sometimes halt it. Talk about that. This was the situation when I entered it. The costs, similarly, are enormous. Private insurer, Medicare, Medicaid. 40+ thousand average annual direct and indirect costs. I'm sure it's double that today. Billions and billions of dollars. So I'm going to stop, move into the marketplace and some of the drugs in a minute. Can I pause here and see if anyone has any questions? Okay. We'll keep going. So the market at the time, 2007, was under $4 billion. It's multiples of that today. And yes, it had the potential to grow, and it grew 2 to 3 times that. We start to see, and now we have more drugs in different classes. The interferons were available: Avonex, Betaseron, and Rebif. We had Copaxone. We had Tysabri, a monoclonal antibody, effective, but it had some issues. We had low-dose chemotherapeutic agents, and this was an interesting pharmacological development using the immunodepressant effects of low-dose chemotherapy as a therapeutic effect. Okay, we think about systemic cytotoxic chemotherapies as being immune depressants and suppressants. That's true, but in the case of an autoimmune attack, that's therapeutic. So very often anti-cancer drugs in low doses have been used, as have oral immunosuppressants used for transplant, like azathioprine or Cellcept, mycophenolate. Steroids are used to halt acute attacks. And then we have the oral agents coming forward, Gilenya, Aubagio, and Tecfidera was coming on, wasn't yet approved, but it was coming on and became a blockbuster. That wasn't in the market when I was working with the Novartis and Sanofi on Gilenya and Aubagio. But by and large, the drugs that were approved, even the earlier interferons, reduced T cell migration across the blood-brain barrier. T cells should not be in the brain for the most part, right? So by suppressing T cell activity, you will alter cytokine secretion and the inflammatory cascade. And they all have an X beta signaling with all its similar mechanisms of action. The polypeptide Copaxone may have been a kind of a surrogate agent. Tysabri, natalizumab, humanized monoclonal, targeted the integrin protein expressed on the surface of T cells, profoundly immunosuppressing, and also caused some brain viral infections that were problematic for its use early on until they were able to screen for that. We talked about the chemotherapeutic agents, steroids, obviously, to halt an acute attack. And if you look at the market, as I mentioned, in 2007, when the oral agents were coming to the market, we had about under $4 billion. With beta-seron and Rebif and Avonex, the interferon agents dominating the marketplace. And growing year by year. And they checked the box in a couple of specific areas. They had indications for relapsing and remitting. Not so much for progressive disease. And physicians view Tysabri as the most effective, but also the most potently immunosuppressive. And so held it in reserve. And doctors, neurologists for the most part, don't prescribe concomitant agents. Can anybody tell me why they would be reluctant to use an interferon with a steroid or a low-dose chemotherapeutic agent? What would be the rationale for avoiding concomitancy in pharmacotherapeutics in this situation? What do you think? Anyone? What would be the potential harm in adding these agents together, which they just don't do?
Does it suppress the immune function a lot more than it should?
Exactly. Who is that?
Serge.
Yeah, that's exactly why. Because they have additive immunosuppressing properties that, yeah. And that could lead to all kinds of problems, including hematologic cancers. So this wasn't done. So they tend to hold these drugs back and wait for a patient to fail. And then they go to the next one and wait for that to fail. Well, what's happening when the patient's failing? What's going on in the brain and spinal cord?
They're losing myelin.
Yeah. And possibly permanently, the accumulating lesions. We know that the accumulation of lesions in the central nervous system is correlated to reduced EDSS scores, expanded disability scores. So it was a very tricky disease to manage with few good options because all the drugs failed eventually. So you could see some of the trends with regard to annualized relapse rate. The AAR is a powerful marker on the y-axis over 2 years. So you want to have less, lower the number, the better, fewer annualized relapses. And you can see how, and this is not head-to-head data. These are not done in the same trial. So it's meta-analysis type of work, systematic literature reviews. But you could see in non-comparative data how some of the, you can see natalizumab had a lower rate than interferons, GA's glutamine, and alemtuzumab, another very potent immunosuppressant, rituximab, FTY, I believe was the generic name for the Novartis compound, Gilenya. There are also patent extension issues, patent expirations that were occurring over that period of time, putting additional pressure on the marketplace. And MS products provided modest efficacy at best, but didn't really prevent relapses, as you can see here. Tysabri, I added this data, had some of the lowest relapse rates. You can see these low numbers. Percent relapse free was over 2/3 compared to these other categories. But Tysabri also had a virus, the JC virus, causing PML, that would be a certain death. So there's a rare brain infection called progressive multifocal leukoencephalopathy, PML, caused by the JC virus, which is a slow-acting virus in the brain. And so patients who were previously exposed to the JC virus, when they got Tysabri early on before they screened for the JC virus, some patients died from Tysabri related to PML, which was uniformly fatal. Nobody knows for sure how the JC virus is spread. You may pick it up through food or water that had the virus in it. Apparently it's a central nervous system slow-acting virus, possibly a cytomegalotype virus, somewhat related to the discovery of the people from Papua New Guinea, the early description of Kuru. If any of you are familiar with this story, Nobel Prize was awarded for the elucidation of the slow-acting virus that was a cytomegalovirus causing Kuru in the ceremonial ceremonies in the people who lived in Papua New Guinea would consume the brains of their deceased. They were dead, but they would get a JCV type virus 20 years later, 25 years later. There's evidence of the first slow-acting virus. This suggests that the JC virus is a slow-acting virus related to the cytomegalovirus. I mentioned this, which is an interesting anecdote. They did eventually have a screening tool. So patients who were potentially going to go on Tysabri, natalizumab, had to be screened to see if they carried the JC virus. If they did, they would not get Tysabri. But if you didn't have the JC virus, you had essentially minimal to no risk of developing PML. Anti-Sabri was clearly, in those days, the most effective agent, but there was concern about it, so it was put in second or third line, fourth line. The industry was spending extensively on direct-to-consumer meetings, journals, and promotional detailing through Salesforce. Difficulty in differentiating the interferons from each other, frankly, from any of these drugs from each other. Because that's all they had, neurologists were reasonably satisfied. I think if you looked at it compared to today, we have many more effective drugs, but the satisfaction was not zero. At least they showed some efficacy in early relapsing remitting disease. And once they failed one, they go on to the next until nothing worked. Patients were similarly satisfied. Is there a cutoff age? Could one not get it when they reach a certain age? You talk about MS, cutoff for MS, I assume?
Yes.
It's a fair question. The chart I showed shows that people can get it into old age, but it's much less common. So part of the answer to that is what's causing it, and if it is a Epstein-Barr virus, how does one get an Epstein-Barr virus? Anybody know? Epstein-Barr virus. It's a member of the human herpes simplex virus. It's spread through body fluids, infected people, sometimes sneezing or coughing. But I think insofar as the Epstein-Barr virus might be part of what happens in sexual contact, as people age, I think there's less contact. And so I think the potential for an Epstein-Barr virus contagion goes down with age. There you go. Someone just spelled it out better than I did. Yeah. Coughing too. So it's not just sexual contact, blood transfusions, organ transplants. So it's not zero in older age, but it's much less. The interferons at the time were injected, are injected still are when they're used. And people didn't like those injections, like it all injecting with insulin. And when you gave yourself an injection of an interferon agent, beta-seron, Habenex, Rebif, you'd often develop flu-like symptoms for a day. And you would inject yourself once or even twice a week with these agents. So on top of all the miserable symptoms of this dreaded disease, now you feel like you got the flu once or twice a week with these drugs. This is just awful on every level. Inadequate therapy, full of side effects that ultimately failed, on top of a myriad of symptomatology that were just terrible. Is MS seen, Ania asks, in a certain demographic? And if so, would that mean there's an identifiable genetic reason? Been theorized, more common Caucasians than women, but not so much if it's secondary progressive disease. And it's equal with men. Yeah, maybe it is Caucasian. I don't know enough about that. That would be interesting for somebody to report on next week. Emily, could you do some research and tell us more about the demographic of diagnosis of MS by Caucasian or other factors?
Well, when I was looking into it, I think I forgot what year this study was done, but they said that the most common demographic that experienced MS was Caucasians and sometimes African Americans, whereas Hispanics and Asians were it was less likely or less seen in the population.
Yeah, I don't think there's any good explanation for that I've seen. Okay, thank you. And patients, though, were very active. You know, neurologists and the patients with MS really were very, very engaged in discussing treatment options with their patients. Yeah. At the time, patients switched around a lot, as you can see here. You know, after a few years, you move on to something else that worked better. Today, there are, as I said, many more options, but a lack of efficacy, increased side effects, inconvenient dosing, cost, were all the drivers. Majority of patients had been on their current therapy for about 2 years or so, 2 to 5 years. But adherence and compliance are high. It's a highly symptomatic condition. Patients want relief. And they're very engaged, very knowledgeable about their condition and the therapeutic options. Yeah, Rebif was 3 times a week. Awful. Side effects, lack of efficacy, as I mentioned, were reasons for discontinuation. Condition gets worse. Doctor suggesting a switch. As we mentioned, combination therapy is very rare due to the profound immunosuppression, safety concerns, opportunistic infections, PML with Tysabri. Payers were pushing back on the cost. But then along came a lot of research. I gave a talk actually at Hopkins on this topic to their research scientists in neurology and neuropharmacology, and told them what I thought about the current state of affairs. And not that that had anything to do with what happened, but over the next decade, we saw an awful lot of agents, as you see here, coming forward in development. We saw fingolimod, so-called FTY-720, a sphingosine 1 receptor agonist, traps the lymphocytes into the lymph nodes, lowering the number of activated T cells in the bloodstream and the central nervous system. Teriflunomide from Aubagio from Sanofi, inhibiting proliferation of activated T cells. Cladribine, powerful immunosuppressant, alemtuzumab, and others. You can see here the plethora of agents that were in development in the pipeline. So from being for 30 years, a quiescent, sleepy, desperate need, unmet need situation to quite a few novel mechanisms of action, fortunately. And you can see that these new oral agents appeared to be only minimally differentiated. So that was the issue for the introduction of the agents. They really have to differentiate themselves from an efficacy and safety perspective. And it really was more about safety, with focusing on Gilenya and Aubagio in this case. But uptake was expected to be strong because remember, the interferons, Rebif, Avonex, and Betaseron were all injectable. So was the occasional use of Tysabri or alemtuzumab, injectable or IV monoclonals. Patients were afraid of the needles, the side effects from those injections. Orals were very attractive. And so the oral formulations came along, and they were very desirable. They were going to be compared to the injectables if they had greater, as good efficacy with greater safety. That would have been a home run. So I'm going to transition now to discussion of the work I did with Sanofi Aventis on Aubagio and what they did to bring this first oral agent to the marketplace. So this is an important slide, students. You do need to have an understanding of this pathway. I'll tell you why. Because Aubagio, teriflunomide, at its oral dose of 7 or 14 milligrams, selectively inhibited dihydroorotate dehydrogenase, the DHODH enzyme, selectively. Why that was important? Because that downregulated the blasting lymphocyte, that T cell pathway, while maintaining the resting lymphocyte. So you maintain your basal salvage pathway. So unlike many of the earlier agents, Tysabri, alemtuzumab, even interferons, that didn't differentiate between salvage or call it resting basal immunity, it really focused more on the exacerbated inflamed immune system, the blasting system. It's a little bit like the discussion of COX-1, COX-2, only this time it's an immunopharmacologic argument. And I do need you to know this, because this is one of the take-home messages of this lecture, that the way that we differentiated Aubagio teriflunomide from all others was that it focused on this pathway and allowed us to separate and maintain a basal salvage immune system. So you were not as prone to secondary infections and cancer, hematological cancers if you took this oral agent Aubagio, because it focused on the DHODH pathway. It didn't occur in this salvage pathway in non-lymphoid cells, maintaining basal immunity. Let me pause there and make sure you understand that, because that is a key takeaway for this lecture. Any questions about this? Okay. I'll take that as that you get it. I mean, it's pretty straightforward once you think about it, once you see this. Why this would be so attractive, teriflunomide Aubagio, selectively inhibiting one pathway, not the other. It produced nice, I call it 2-year downward, annualized relapse rates that you saw in the earlier slides in comparison to others, sustained disability. And all of a sudden we start to see evidence of brain volume. When I moderated the advisory boards around the world for these companies back in the day, we talked about brain volume loss, or the percent brain volume loss. And what they really were talking about is that the accumulation of lesions in MS eventually results in black holes, they call them, in the brain. Dead tissue that didn't function, wasn't coming back. And so the change in the volume of white matter or total brain volume was being measured somewhat crudely, I would argue, by contrast enhanced MRI, but eventually much more specifically. And so another mechanism or method of differentiating these products were their effects on brain volume loss, BVL. That's something else I need you to know. And I tell you these things, why you need to know this, because this is an important concept in immunopharmacology, not just in this space, but in any space. And brain volume loss, for anyone who works in the field of neuroscience or neurology or musculoskeletal disease, that's a consideration, particularly MS or any neurodegenerative diseases like Alzheimer's disease. The lessons learned here, the ways of differentiating these agents continue. Maybe it's not these agents, Aubagio and fingolimod, but it doesn't matter. The method of differentiation is based on the same science, same pharmacology. But offering a pill that was as effective as most, but clearly more tolerable, was considered to be of value to customers.
A question, Professor?
Yeah.
In the earlier slide, for the placebo, since we don't have a data, does that mean it's like there's 0% of reduction in the BVL, the total lesion volume? Shouldn't we be expecting at least, brain volume loss generally in multiple sclerosis?
Yes, there would be brain. The question is, what impact did these drugs have on the rate of loss? So it's a bit of hitting a moving target, but you're right. You wouldn't give placebo to a person with MS, it would be unethical, so we don't know what the total brain volume loss might be. But you can see here that Well, maybe they did, frankly. Maybe they must have given placebo because it's right here in the chart. I don't think that could be done today. Let's put it that way. But if you
Thank you.
had placebo being given to these patients, which I find amazing, that way you can measure a difference between the different doses, 7 and 14 milligrams, and a reduction in brain volume loss, a significant reduction in brain volume loss compared to placebo. Again, it's a good question, Tenzin. I don't think this kind of a study could be done today for the reasons mentioned.
Dr. Sigarnik,
Yeah,
a quick question, sorry. If you said we're not giving placebo, like nowadays we wouldn't give placebo like to an MS patient due to like moral reason. If we're not giving placebo, like I'm assuming that's kind of a standard thing in pharmaceuticals now, like across the board, like we're not going to give placebo to someone who's like signed up for a clinical trial, who's signed up for something that's very like taxing and draining. While we're not doing that, how do they balance the line between like we're not giving a placebo group, so we have no idea whether or not like we have this data versus the like moral implication of like we're not going to give a placebo at all?
so I think, Brian, the answer comes down to in conditions where we know we've got a effective standard of care, you can't ethically withhold standard of care treatment from a patient with a serious disease. Almost any condition, it's unethical. So I think that placebo control may be desirable. And in many conditions, we have no good treatment. So you can use a placebo. Especially today, most of the work I do is in treatment-resistant diseases, rare diseases. There are no therapies. There is no considered standard of care. So there you can give a placebo. But I think in conditions where we've got a really effective agent, and you know, you got to take them one at a time. Maybe there's some circumstances where for a short period of time in a non-fatal condition, you can get away with it for 12 weeks, let's say, maybe. But I think it's tricky. When you've got an effective therapeutic intervention, you withhold it. I don't know about that.
Yeah, doesn't seem like you make it very popular. Thank you.
Or acceptable or ethical. But we were in very early days here in the MS field. So the question is how to differentiate teriflunomide, Aubagio. Was it better than the other oral, Gilenya, coming forward? What it mean from a cost and expense perspective, from an outcomes point of view? Was it as good as or better than the monotherapies with interferons? Were patients going to comply? One of the reasons to give an oral was the patients would comply better. Although compliance was already pretty good, because patients want effective treatment for such a symptomatic condition. And so teriflunomide came along, and it was this DHODH inhibitor, oral tablet once a day, in 2 dose formulations without titration as monotherapy. And that was how it was approved. And these were the multiple clinical trials that were done all around the world. And sure enough, from a strength, weakness, opportunities, and threat perspective, there were some real benefits. The oral dosing, a very nice balance of benefit and risk ratio, just as good in efficacy as the interferons with greater safety and tolerability. A proven safety profile, had no evidence of malignancies or serious systemic infections. That's pretty powerful. Because all the other agents, Tysabri, Metalizumab, all the interferons, Tuzumab, everything else suppressed the immune system so profoundly that they'd see occasional, not commonly, occasional hematologic malignancies, serious systemic infections. Which over 10 years from at launch, they've been studying this compound, didn't see it. A novel mechanism of action, not that in and of itself a reason to prescribe it, but selectively targeting protecting the salvage pathway and targeting the blasting pathway. Very attractive pharmacological rationale. It was not, though, better than other therapies from an efficacy alone perspective, so there wasn't a great breakthrough. Today, we've got some much more effective agents on the market. And so the scientific narrative, which is what this scientific platform is essentially, is that there was a need for a simplified oral therapy with proven efficacy, predictable safety, and greater tolerability. And Aubagio had a unique MOA that reduced the number of rapidly dividing and activated T and B lymphocytes implicated while preserving the normal immune function. That's huge. It also attenuated white matter atrophy, reduced the formation of black holes, a measure of neuroprotection, a buzzword of neuroscience and neurology, neuroprotection. And in the phase 3 trials, it demonstrated that efficacy and safety profile. So it became a new once daily oral treatment, a great option for patients with relapsing or remitting disease, with a unique MOA that targets the de novo pyrimidine synthesis, reducing activated blasting lymphocytes, T cells, preserving normal immune function. Didn't require any fancy monitoring, had very good long-term safety data. So it was an attractive compound. I'm going to shift now to the work that I helped support Novartis with the introduction later, that came shortly after I worked on Gilenya as well. You can't work on the same compound at the same time for obvious ethical and business reasons, but no reason you can't work on different compounds at different times. And here you see the Gilenya fingolimod phase 3 freedoms trial data showing even greater reductions. Remember, I showed you 0.39, 0.36 at the 2 doses of Aubagio, teriflunomide. Here you see 0.18 points greater reductions in the ARR, making more patients relapse-free, disability progression-free. And look at the percent change in brain volume loss, much greater. So really an enhancement of all the benefits that Aubagio was claiming, Gilenya was claiming, even greater. And in fact, the percent brain volume change, PBVC, over time, correlated with disability progression over time, as you can see here. Reduction in disability progression and percent brain volume loss by year, and annualized change in the EDSS score would go down with the reduction in the percent brain volume loss. So they were clearly correlated. And this shows that whatever stage of MS one was in, clinically isolated, relapsing, remitting, secondary progressive, or primary progressive, brain atrophy rate occurred similarly across those conditions. One could argue could be potentially somewhat additive. And there were many factors that we were arguing mitigated brain volume changes, tissue loss versus regeneration. We know the brain does to some extent regenerate, as opposed to what we were told earlier on. And we had the fact that really none of the other agents in MS therapeutics significantly affected brain atrophy over 2 years in clinical trials. Teriflunomide, as I showed you, had some of that data, but certainly it was very spotty. But if we looked at the consistent data that Gilenya fingolimod demonstrated on brain volume loss across their phase 3 trials, the Transforms Freedoms 1 and 2, you could see the significant reduction that was somewhat dose dependent over 24 months here compared to placebo. And that as those extension trials continued, that reduction continued over time. That the mean percent change in brain volume loss continued over time. That we felt was correlated to clinical utility and efficacy, as demonstrated in these pretty remarkable numbers for an oral agent. This looks an awful lot like metalizumab and other potent immunosuppressant agents, but in an oral. And so that was the basis for the differentiation strategy. So the 2 take-home messages for you for this lecture is on the one hand, the specific targeting of the DHODH pathway by Aubagio and its implications for T cell migration into the brain and its safety. The maintenance of a salvage pathway or basal immune salvage pathway. Here, I think the biggest story is the pretty profound efficacy and the relatively long-term 4 or 5 year long-term data showing a continued reduction in brain volume loss with Gilenya. Now, along came Tecfidera from Biogen, and that product is even generic today, and others like it that continued along this path as an oral agent that became a real blockbuster. It differentiated itself also on efficacy and safety. This lecture doesn't get into that because I didn't work with them. All these are based upon my specific experiences. But suffice it to say that both Gilenya and Aubagio continue to this day to have a place in the pharmacological armamentarium for many of the reasons mentioned. Although we have many more agents today, including monoclonal antibodies from Roche and others that are quite effective, fortunately. But the question for you from the Sanofi Aubagio perspective is, did Aubagio make its case as the preferred agent based upon its mechanism, brain volume loss, safety? What do you think? What's your impression? Looking at it from the Sanofi Aubagio perspective, what do you think? Anyone? From the specificity perspective, in this case, do you think it made it from the clinical perspective? Did it carry over into the clinical utility? Because specificity and selectivity are only important in terms of whether they have a clinical impact or not. So did it have a clinical impact? Yeah, I don't think from the, what about from the safety perspective? I
It had a
agree.
better safety profile, I think.
What?
It had a better safety profile, I think.
I think that it was mostly about safety. But Gilenya, I think you would agree, had both an efficacy and a safety message. More based upon brain volume loss attenuation. And that really was the message of this lecture. You can see here that Gilenya really was a bigger agent. It's $2 billion at its peak. Aubagio got half of that, but still, these are, talking about 590 million to $1 billion a year in projected sales. And I don't know what this ended up actually looking like in reality, but these are some really big numbers. So any other comments or questions, students? Those are the take-home messages for today. And that's the story of Aubagio and Gilenya, the first oral agents in MS.
Hi, Professor. I had a question about where the market is moving today, because I used to work in an MS clinic, and I saw that a lot of the patients were on Ocrevus, which is a monoclonal antibody that they only get like an infusion every 6 months.
Yeah.
So I was wondering if the market now is like more towards that than oral.
I think it is. I worked on Ocrevus in its launch. It's a terrific drug. And I think that, I think we moved away from, fortunately, start with beta serum, start with a beta serum or Rebif, and then wait till you fail and move to a oral wait till you fail. I think patients are starting with Ocrevus and being more aggressive with therapy right out of the gate, because we know that, you have to stop the accumulation of lesions right from the start. So, again, was not the marketplace when I was there. It certainly has evolved in a very positive way, and there are other agents as well.
Yeah, definitely. I noticed that a lot of the patients would stay on Ocrevus for like if they started it right away, if they just came in and got diagnosed, like they would get started with Ocrevus. But for like patients that had MS for a long time, they would stick with whatever they had and worked for them.
And maybe wait till it failed.
Yeah.
Yeah, fair point. Any other comments? In fact, Ocrevus was the only drug approved for primary prevention of primary progressive disease. It may still be the only drug approved for primary progressive disease, aggressive disease out of the gate. Yeah, go ahead.
Yeah, I just had a quick question. So I know that MS is very dependent on like the climate that you're in. Like for example, in warmer climates, you won't have as much have as many MS patients versus in colder climates there'll be more. Is there any differences in drug prices or how insurance covers MS depending on where you're living?
Not that I know of in the US. You're talking about in the US, cold versus warm climates?
Yeah, I guess US and also worldwide.
Well, worldwide, the prices will vary tremendously by virtue of the nature of the payer systems that they work in. You know, we don't have a single payer system. You know, virtually all of Europe does. Many countries do. And we don't have as many cost controls. They have many more cost controls. So the prices will vary tremendously. And some of these drugs can be quite expensive. So yeah,
But then you'd say in the US it's pretty much the same depending on where you're living.
Yeah, I think, you know, each payer negotiates their own price. The Blue Cross Blue Shield versus Humana versus somebody else, but by and large, the drug companies charge the same amount across the US, regardless of the temperature. And that may have the epidemiology of the disease may have something to do with the prevalence of the Epstein-Barr virus in colder versus warmer environments.
I have a question. So I know you mentioned something about there was a slide where you talked about the disadvantages of taking corticosteroids. Yes. And so you mentioned that the disadvantages of taking them, like it causing infections, like higher increases your chances of getting infections. And I wanted to know if you're taking medications like prednisone and tacrolimus, is that if you're cause and you do not have MS?
So you froze there for a minute. I got the drugs you mentioned. You asked your question again?
If you're taking that and you do not have MS, does it still cause the same effect? Or does it not? Like if you're a kidney transplant patient and you're taking that, can it still cause long-term effects?
Well, it can certainly cause prednisone, most potent steroid, is often used in many conditions to attenuate an acute attack of one form or another of an inflammatory nature. It is just rife with side effects of all kinds. Immune suppression is certainly one. So even if you don't have MS and aren't taking other immunosuppressant agents, prednisone, if you're otherwise healthy, you'll have somewhat less of a risk, but not zero. The risk of prednisone, even acutely in immune compromise, is real. In young children, it can also cause, regular use can cause growth suppression and infection. So they're very powerful agents and they have their place, but they have to be used prudently. And if somebody's got renal disease or whatever, any kind of condition, comorbid condition, the risks to them are greater.
Okay, thank you.
All right. Okay, students, I think we could make it a wrap for tonight then. Appreciate it. If there are any other questions, again, you've got that online Canvas bulletin board where you can post some questions during the week. I think we had a few follow-ups, so please report back to us at the beginning of class next week. Always thank you for your time, appreciate your attention, and have a nice rest of your week.